Let's get started with the second part. Is there enough people back? Is everybody around? All right. So we will start with looking at video. All right. Who would like to comment on what happened? Anybody, just say whatever you saw. There's no wrong answer. You're just telling me what you saw. Any volunteer? ايوه تفضل.
Hello, Doctor. At the beginning, she had complex partial seizure. Okay. After about 30 seconds, the seizure became generalized in her whole body, in her legs and arms.
Good.
Yes, this is what I noticed.
Okay, so I'm just gonna go through this again. Very good. And I'm going to point out all these things. So right now she's just trying to open something. Her legs uncrossed. They're making non-specific movements. وكأنها سرحانة شوية. Okay, so she's complex. She's lost consciousness. Okay, head is being turned to the right side a little bit. Okay, so that tells me it might be there a focus somewhere that's turning it to the right side. Now, tonic phase. This is the tonic phase. Arms are stiff. There is clonic activity, but most of it is tonic. Okay, posturing. Look at the hands posturing abnormally. Some noise from her mouth, vocalization sometimes happening. And now clonic. It's becoming more clonic. You have large jerking movements, okay? So this is generalized, right? Clonic, clonic. Still clonic activity, but it's beginning to slow down. And then they turn her on her side, so in case she's going to vomit or something, and just wait for it to subside. And after that, she's unconscious. She's in a post-ictal phase. Okay, was that a clear example of tonic and clonic activity? Right. Let me see if I've got another example. This is a good example of something more, not generalized, but complex partial. So, see the girl's lying down, and now her left face is twitching. And the left face twitches, and the head begins to turn left. So something's happening in the right brain, making her left side move like that. Right? And now her left arm, and it's spreading to the left leg. The right side is not doing anything. Very prominent clonic activity on the left side. And then it stopped. So that's more like a focal. It really tells you it's a focal process when it's not generalizing, okay? That means there's probably something focal in the brain that's done this. Now, remember when I said about sometimes people confusing syncope? This is an experiment. Let me just give you some background here first. So this is an experiment. They had some volunteers. They squat. They sit down in a squatted position. So that really increases their venous return. After a period of time, they stand up really fast. Please do not try this at home, okay? They stand up really fast and they induce syncope. The blood doesn't have enough time to rush to the brain. And so when they stand up, they lose consciousness immediately. These people have what we call some jerking from the syncope. It is not really a seizure, but you can see how it is easily mistaken for a seizure. But it's really chaotic movement, asynchronous, مش ماشية مع بعض. كل حركة كده لحالها, these soft twitches وتخلص بسرعة. All right. Let's go to, no, not this screen. Okay, you can see the new screen that says management of status epilepticus. So we're going to discuss this one. All right. Excuse me, I have a bit of a runny nose today. Okay. By the end of this lecture, we want you to kind of get an idea about the definition of status epilepticus and approach to managing a person in status epilepticus, okay? So we all know that seizures can be dramatic and frightening. We know what a seizure is caused by. And we know that it may be focal and it may be generalized. So a definition of status epilepticus, so it's defined as 5 minutes. Remember when we were talking initially, we said 20 minutes, but really a strong recommendation is to consider it more like a 5-minute event. Once the seizure is going on for 5 minutes, the chance is really small that it's going to subside by itself if you don't do anything. All right. Refractory status epilepticus is defined as status epilepticus that does not respond to the standard treatment regimens, such as an initial benzo followed by an anti-epileptic drug. And the etiology of status epilepticus should be diagnosed and treated as soon as possible. Okay? So here's looking at the causes of epilepsy or status. A lot of times, as I mentioned, it's medication non-compliance, anticonvulsant withdrawal, alcohol withdrawal, cerebrovascular, metabolic, trauma, drugs, sinus infection, tumor, congenital, previous epilepsy, and idiopathic. We talked about generalized tonic-clonic, and we saw some videos. All right, so if you receive a call at night that your patient is having a seizure, what should you do? So these are the questions you're going to think about as you're walking to your patient. Is the patient still seizing? How long has it been going on? What's the patient level of consciousness? Is this the first known seizure for this patient? Is the patient on anticonvulsant medication? Is the patient diabetic, right? All of these are important questions. If it's diabetic, the first thing you're going to think about is hypoglycemia and blindly give them some sugar. No problem with that, okay? Hypoglycemic attack is probably more dangerous than being in hyperglycemia. So don't worry about getting the sugar up too high. So if the patient, you come there and the patient is still seizing, you think this patient has status epilepticus. You have 2 IVs set up ready at the bedside. Make sure there's an oral airway. These patients are unconscious. And sometimes if the seizure is prolonged, they risk aspiration. You want to protect them from that. Sometimes your drugs are going to cause excessive sedation, and you need to be able to rescue them. You're going to start with something like lorazepam or diazepam. You have to be ready at the bedside for a quick administration. Clear any sharp or hard objects from the bed. Put the side rails up. Pad everything as much as you can. And you can check the blood sugar. But it's okay to order like dextrose or something to give to the patient in case it's going down. So we discussed about the differential diagnosis of a seizure. Remember that? We said it could be TIA, could be a syncope, could be an abnormal movement disorder or tremors. So here's a helpful mnemonic. When you want to think of a seizure, what has caused it? You want to think of like a vascular lesion, like a stroke or a hemorrhage. An infectious process is causing the seizure. Is trauma? Did this patient have a head injury that's causing the seizure? Does the patient have an autoimmune disease? These can cause seizures. And is there a metabolic problem like hypoglycemia or changes in sodium, hypernatremia, hyponatremia, calcium changes? Is it idiopathic? Is it neoplastic? Okay, and these nicely spell out vitamin for you. Okay, so if you remember vitamin, you'll remember all etiologies for most neurological diseases. And S, structural. Structural is kind of similar to neoplastic. Treatment of an ongoing seizure. So you need to keep calm, and it's likely that everybody else in the room is not calm. You have to ask the family members to leave the room so you can work comfortably if you need to, and that you'll speak to them. Ensure that all measures have been taken to protect the patient from physical injury and aspiration of gastric contents. If you're at home and a patient has a seizure, you just turn them on their side and make sure there's nothing next to them that they would hit. Do not try to hug or hold the patient. Just give the patient space to move, to act out the seizure. Okay. But in a hospital, you pad the bed, make sure it's not too tight. Also, there's room for the patient to move. Administer oxygen by nasal cannula or face mask watch and wait for 2 minutes. A majority of seizures will stop spontaneously within a short time. Okay, so in reality, you're not just watching and waiting, okay? It's kind of like you're mentally waiting to see if this is going to progress or not. Because when you see a person having a seizure, the first thing is going to ask your nurse to prepare the Ativan. You don't want to wait 2 minutes. So let the Ativan come and see what happens. Say the patient stops quickly. It's optional. You could give them or you could not give them. I would tend to give them if they've had a seizure and they're in front of me in the hospital. All right. And then you would follow and see how they respond to it afterwards. Check the blood sugar level. Again, this is placed multiple times because it's so important to check the blood sugar, because you would treat it not with anti-epileptics, but you would treat it with sugar. Make sure there are 2 IV setups available. Okay. Again, you draw your diazepam starting with 5 milligrams or 4 milligrams of 2 milligrams of lorazepam. Make sure you got all the history you need. Also ask if there's any toxins, any other causes. And then you also want to know if the patient is on an anticonvulsant or not, because if somebody's already on an anticonvulsant, let's say phenytoin, and I want to treat the seizure with phenytoin, I'd want to know if this person is compliant or not, because it will affect how much phenytoin I will give him, just so I don't put him into too much toxicity with the drug. All right. If the patient is febrile in the last 24 hours, you want to know if there is a fever, because you would want to look for meningitis or even start IV antibiotics in this case. All right. So this is your first approach. We're going to come to the next step. After your benzos, and the seizure has not remitted in 2 minutes. Let's see, avoid anticubal area. Okay, these are just some recommendations on where to insert the IV site. So don't put it in the antecubital area, because there might be excessive flexion and it'll block off the IV site. You want to do screening blood tests. I forgot to mention, this is important. You want to check, of course, the electrolytes in addition to the blood sugar and everything. We talked about giving glucose. If there is any history of alcoholism. If a patient you think is malnourished or is an alcoholic and doesn't eat and just drinks alcohol all the time, you would administer thiamine 100 milligrams slowly. You have to give this maybe, sometimes we give it once a day, sometimes we give it 3 times a day, depending on the degree of malnutrition the patient looks like. You should give it before the glucose, because thiamine is used in the glucose pathway, metabolism pathway. So if you give glucose before and there is thiamine deficiency, you would make the thiamine deficiency worse, because the glucose demands thiamine be present. So make sure that they've got thiamine. And we mentioned the face mask, oxygen ambu bag, and airway assist devices are there. All right. So if the seizure doesn't stop with a full dose of benzo, you go to your next step, which is typically phenytoin. Some studies are showing that we can use other anti-epileptics, but we're just going to go with the traditional pathway right now, which is using phenytoin, about 15 to 20 milligram per kilogram as a slow IV infusion. The rate of administration should not be more than 50 milligrams per minute, so you can avoid some of the side effects. That's the fastest you can give. ECG should be monitored continuously, and the blood pressure should be checked during the infusion, because it can cause arrhythmias or severe hypotension. 70% of prolonged seizures will be brought under control with these methods. Some patients, if they're still seizing and they're not recovering their consciousness well, you might have to put them in the intensive care unit. They might need to be intubated. So here's a good diagram. So you can start with lorazepam or diazepam, followed by phenytoin, or phosphonytoin is more rapidly releasing. It's not available here. We use phenytoin. Phenobarbital could be another step, or an alternative to that is midazolam. I think more people are shying away from the phenobarbital, and we're tending to use more midazolam and propofol. And then later on, if it's still going on, you're going to use heavy anesthetics like pentobarbital. Once the patient's in the ICU, if the patient is still having a seizure despite full phenytoin load, the next step is to use the barbiturates. Phenobarbital could be infused. 20-30% of patients continue to have electrographic seizure activity that is not clinically apparent. So that means I come to this patient and I put an EEG on him, and you'll see that he's still seizing despite no obvious clinical movements. So these still need to be treated. Alternatives to phenobarbital include midazolam. And I like to say that nowadays, midazolam has probably gotten much more popular than phenobarbital. So you just put them on a midazolam infusion. General anesthesia with halothane and neuromuscular blockade has been used in some cases to avoid rhabdomyolysis, but this eliminates the ability to follow the neurologic exam. So these are paralytic agents are dangerous, right? Paralytic agents, they paralyze the person. Person will not be able to move. It does not mean that the seizures have stopped. It has no effect on this. So they only use this sometimes just for intubation in some cases. But in reality, you don't need them that much. Okay, this is an algorithm for convulsive status epilepticus. I'll just walk you through it here. I think we've covered everything for it so far. 0 to 5 minutes is when you want to stabilize the patient and assess if the seizure is going to continue or not. Time you get this is when you get your history done. This is when you get everything ready and the cannulas. This is when you get your medication ready in the first 5 minutes, okay? And then the 5 to 20 minutes is when you have to be a bit more aggressive. So if the benzodiazepine is not working, you can go with the next step, which is the phenytoin, valproic acid, levetiracetam can also be used. Not a lot of evidence is available to what to do if it's still persistent in these cases. What we tend to do is just put them to sleep completely with anesthetics as best as you can, and you monitor the EEG until you really suppress brain activity. On the EEG, you'll see suppression of brain activity. And then you will start to withdraw from the anti-epileptics a period of time. It's almost like doing a restart for your brain, like you do for your computer when it starts working funny. You turn it off and then turn it on. The same thing. Once you give heavy sedation, you've kind of suppressed all activity in the brain. You've turned it off and you're letting it restart again. This is just showing generalized discharges. And these are just periodic spikes indicating epileptiform activity. All right. Mortality and status epileptics by age group. So of course, mortality is high in the elderly patients. The older the person is, the higher the risk that of death. So complications of status. With time, there could be tachycardia, arrhythmias, respiratory problems, which is why you want to intubate to protect their airway. Hyperthermia could happen, metabolic derangement, cerebral and neuronal damage after very prolonged seizures, death in about 2%. So things that are threatening to life, like aspiration of gastric contents if the airway is not protected, head injury, lactic acidosis, hypoxia, hyperthermia. These other metabolic disturbances could happen. So make sure the patient is positioned on their side if they're at home to prevent aspiration of gastric contents. So depending on the etiology, this is the likelihood of death. High mortality if a person has like anoxic brain injury. and multiple medical problems or sepsis. Low mortality if epilepsy, and like it's due to reduction of the drugs or medication or drug toxicity or alcohol withdrawal. Everything else is kind of an intermediate mortality risk. So in summary, you want to maintain the airway. This is very important. You want to make sure they're breathing, and as part of airway maintenance. You want to make sure you have good access, and you want to avoid the elbow or the cubital fossa with IV access. You always want to check the blood sugar. Don't forget to check the calcium and sodium, because these are big causes for seizures. The main electrolyte imbalances that can cause seizures is blood sugar, glucose, sodium, and calcium. Here it mentions anticonvulsant levels. So some drugs like carbamazepine and phenytoin, you can measure their levels in the blood. If they are below the range, you could say that this person might not have been compliant, and this is why there's a seizure, and you would probably use your anticonvulsant in managing the current event. So we mentioned good drugs are the ones that you can get into them quickly, so a lot of them are going to be IV. There are some pediatric patients where their family member has diazepam that can be administered rectally for some urgent situations. These are the two major benzodiazepines we use, diazepam and lorazepam. And midazolam is used as a third line therapy, as an infusion. The diazepam is highly lipid soluble and has rapid distribution in fatty tissue. Usually ends up at about 5 milligram dose, 5 to 10 milligrams. Lorazepam is less lipid soluble. Stops seizures in about 6 to 10 minutes. All right. Has a longer duration of action. Phenytoin. This works at the sodium channels. It'll take longer duration. So that's why you want to start with the benzodiazepines first. We already mentioned the infusion for the phenytoin and its side effects. Phenytoin, fosphenytoin, as I said, is a prodrug. It's just has a little bit less side effects than the phenytoin, and you can give it faster. But it's not commonly used, mainly because of its price. Phenobarbital is very sedating, so you're going to have to intubate these patients. All right, another option would be the valproic acid. It's also available in IV format. Also, levetiracetam is available in an IV format. Okay, so these are just some recommendations on when to use each drug. I think we covered most of these, but it's a good summary table. This is the evidence available for treatment with these drugs in status epilepticus. Okay, so talking about refractory status epilepticus is just patients who are not responding to the medication, okay? And, all right. Let me show is there. Should be a graph here. Okay. So again, this is a nice page that summarizes everything you're going to do for the patient that comes to you with seizure or status epilepticus. And this is a nice diagram just for you to review, to look at an approach of how to test and investigate patients. So remember, it's a medical emergency that you need to act quickly. Seizure is usually a manifestation of something. If you've stopped the seizure, then you have to continue with investigation to find out what was the cause. And thank you. And I'm happy to take any questions. No questions. Okay. We'll meet again on Sunday. Sunday, we're going to start at 8:30. Okay, we'll do the lectures at 8:30, inshallah. And if there's any questions, you guys can email me as previously. Yalla, assalamu alaikum.